Hello, how are you? Today I want to talk to you a bit about the stepped approach. You may not be familiar with the term the stepped approach, but this is essentially the approach that is recommended for all Western medical doctors, pediatricians, etc., to take in supporting infants with reflux. This is based on what the UK NICE, the National Institute of Clinical Health and Excellence, their guidelines have been both in 2015 and more recently updated in May 2021. And also from the North American and European societies of pediatric gastroenterologists, hepatologists, and nutritionists. It's a big, big phrase. However, their advice came out and their guidelines came out in 2018. So what is the stepped approach? Well, essentially, it involves stepping up the levels of treatment and the severity or the intensity of treatment for infant reflux. So all of the various institutes believe that the first step for all babies with reflux is to reassure parents and to educate parents that reflux is actually a normal physiological process. Now, if you know anything about me, I don't believe that reflux is a normal physiological process at all when it's occurring frequently. So there are elements of it that are common and frequent. But in terms of reflux, when we're talking about children and infants being uncomfortable a lot of the time, regurgitating frequently, like at least once a day, consistently every day, or even more, and being obviously uncomfortable, constantly unsettled, there's nothing normal about this. A baby wants to be happy. So that's my underlying belief. So where we come with the stepped approach is most doctors will try and watch and wait, or just reassure parents that actually it is normal and they should not worry. Being the parent of a baby who had reflux, it's extremely worrying and it's extremely concerning to be watching your baby scream for hours, clearly in pain, and to accept that there's anything normal about this. My guidelines to any parent when it comes to understanding if their child's behavior is normal and acceptable or not is to adopt your baby's symptoms as your own. And if you adopt their symptoms and behaviors as yours, would you be then happy with the explanations and support you've received from the doctors? Or do you still want better answers? Like, would you be happy knowing that it's okay, what you're suffering with, yeah, it might last up to 12 months, maybe more, maybe less, but apparently it's normal. So ask yourself, would you be happy with the response you get? Use that as a guiding tool for you, and use your gut instinct. If you feel your baby's more unsettled than they should be, they probably are. So that first step, doctors are encouraged to reassure parents for as long as possible. If it occurs that baby has marked distress, this is what officially separates gastroesophageal reflux from gastroesophageal reflux disease, is that the disease variety actually has this marked distress. So baby is clearly unhappy. What they suggest first is for breastfed babies to have support from breastfeeding a specialist. They don't actually specifically say who. Certainly in the UK, we have doctors who believe they know about breastfeeding. We have a few doctors who do know about breastfeeding. These people also have an IBCLC qualification. They're also an international board certified lactation consultant. IBCLCs, the lactation consultants, do know about breastfeeding. So if we've got a doctor who's doubled up with that qualification, brilliant, excellent, they probably can help. However, if we have a doctor who has done their 8-hour crash course on breastfeeding, that's probably insufficient to be able to offer practical and proper advice for these babies. The next step for them is to jump straight to an alginate, which is like Gaviscon, which forms a raft on top of stomach acid to make it more difficult for regurgitation to happen. More on that in a moment. For formula-fed babies, The first step is to assess whether baby is drinking enough milk for their weight. And if they are drinking too much for their weight, perhaps reduce that milk. Tick VG, that sounds quite reasonable. Then to have smaller feeds more frequently, maintaining the overall volume of milk intake per day. That could work in some instances. And the third one is then to try a thickener. So to add a thickener or attempt to have a thickened milk. Now, I will say it's really important here because it doesn't say it in the guidelines. Babies should never have a thickener and a thickened milk at the same time. Never. Okay. We should never be combining any of the thickening agents. We use one or the other, not both at the same time. And if these don't work, the next step for formula-fed babies is then to jump to this, to the alginate therapy, which in most cases is infant Gaviscon. I will say it's really important that your baby does not receive adult Gaviscon. In some countries, adult Gaviscon contains aluminium, which is known to be harmful to infants. So please make sure if your baby is on Gaviscon, it is infant Gaviscon that they are on, which is made specifically for infants. Gaviscon, in a poll, a straw poll I did on my Instagram feed a number of weeks ago, where over 200 parents answered, 96% of babies who were on Gaviscon experienced constipation with it. In most cases, parents will decide to take the Gaviscon away because actually the constipation is worse than the reflux was. Gaviscon forms a raft on top of stomach contents, making it more difficult for the contents of the stomach to come up. This is not actually addressing the underlying cause of the constant regurgitation and why that's happening. It's just making it more difficult. It's actually going to create, you're likely to create more problems downstream. If the Gaviscon trial over 2 weeks is unsuccessful, then doctors in the UK should decide whether to refer or to treat. Now, in some circumstances, they will refer directly to pediatricians or to A&E. In fact, we shouldn't be waiting that long to refer to pediatricians or A&E at all. In some cases, there are red flag symptoms right at the very beginning where we can be referring to A&E and to pediatric support immediately. And this is something that I teach to the baby reflux ladies. We all understand these red flag symptoms that flag up very, very early on so that we get them as soon as we possibly can. So if a doctor decides to treat, their next step is then to treat with a gastric acid suppression medication. This used to be a choice between a drug called ranitidine, which was the most popular histamine 2 receptor antagonist or H2RA class of drugs, or omeprazole or any of the PPI medications. They are proton pump inhibitors. These are the medications in which the active ingredient ends in prazole. So we have omeprazole, esomeprazole, which is the active ingredient in Nexium. We have lansoprazole, pantoprazole. We have a number of others, but it's all those medications that end in prazole. And that babies should be trying this for 4 weeks of a trial before it's deemed successful or unsuccessful. Now, in the States, certainly, they have brought back in the use of the medication famotidine. Famotidine in the UK is not licensed for use in the pediatric population, which is in kids under 12 years old. It's not allowed to be used over here for children under that age. In the States, it may be used from 3 months. Different licensing practices. There is a question of, is it truly safe, and what are the measures against 2 different countries with these medications when they are essentially the same medication? The way these medications work is that they suppress gastric acid. They make the acid in the stomach less, they reduce the acidity of it. They actually increase the pH level so that when regurgitation happens, it doesn't actually burn and irritate the esophagus. It doesn't prevent the regurgitation from happening. And that's really, really important. I meet the parents of children virtually and through messages and emails a lot, where medications actually make reflux worse. And parents are told by their doctors that actually you need to see the trial through. You need to stick with it for 2 to 4 weeks to know whether it's going to work. My honest opinion is that we don't need to make things worse than they otherwise were for a child. There's lots of various reasons for that, and I'm not going to go into it here, but there are reasons that we don't want to make things worse for a child, and indeed for you as parents. Things really are tricky enough as it is. And again, these medications do not actually address the underlying cause of reflux. In no baby are they constantly from birth overproducing stomach acid. The body's not designed like that. What we need to understand is, why are they regurgitating? It's not excess stomach acid that's creating regurgitation. The stomach acid that gets regurgitated in the esophagus is completely normal. It is supposed to be acidic to aid the digestive process, to activate digestive enzymes so that children can break down their food and absorb it. Anyway, after a trial of 4 weeks, the recommendations say that we should remove the PPI and see how baby responds, in case they have miraculously decided to release this reflux and stop it forever. Now, in many lots of children, the regurgitation doesn't stop with the addition of medications. It might make it less frequent. In some cases, it can reduce it completely, but it's not because the medication is doing the job. What it's doing is, it's probably in those cases making baby more comfortable. So they're crying less, they're more comfortable more of the time, they're reducing their air intake, and therefore there's no excess pressure in the stomach to cause that regurgitation. We need to understand what is a true underlying cause of reflux. In no child ever is it an underlying problem or weakness in the lower esophageal valve. This weakness is inherent to every single child because the entire muscular system is naturally underdeveloped. Now, the big thing that's missing for me, before I go on, after that 4-week trial of medication, the recommendations say that doctors should be referring to pediatricians or gastroenterologists for further assessment, support, etc. Where baby might be 2 or 3 weeks old before they get the medications. They then have to try thickened milks and changing feed patterns and stuff for 2 weeks. So let's say they start that at birth. Let's say they're 2 weeks into support. Then they try Gaviscon. They should try that for 2 weeks according to the guidelines. They're 4 weeks old. Then they should try PPI medication. They're 8 weeks old by this stage. Bearing in mind, most of the medications, the PPI medications, are not licensed for use under 3 months old. None are licensed for use under 1 month old. And I frequently meet clients whose babies are on the PPI medication before they are 3 weeks old. This is a major, major issue because the doctors are taking on the risk of this. The manufacturers of these medications are saying, we're not telling you that it's safe to use in that population at all. In fact, it should be avoided. So the doctors are taking this risk and nobody's holding them to account. And this is a really, really big issue for me because the biggest thing that is missing from the stepped approach, from anything that the doctors and the medical system does to support babies with reflux, is it never asks the question, what is causing this child's discomfort and pain? It's like they have decided to completely ignore the fact that babies are in pain. They've decided that it's okay for a child to suffer. It's okay for moms and dads and parents around the world to hold their children, being completely helpless to actually help them, not knowing what is going on or why. The doctors have decided that it's okay to completely ignore our true experience of life. This is called gaslighting. And it's dangerous to our mental health. It's dangerous to the bond we form with our babies. It's dangerous to the relationships we have with our partners. It's damaging potentially to children long term by letting them suffer in pain without understanding what is going on. Because I promise you this, when we answer that one and only question that matters, no matter what age a child is, what is causing this child's discomfort, this child's pain, this child's reflux or colic, we can get much better answers. When we understand what's going on for each child on an individual level, we can take very specific actions to resolve the underlying cause of their reflux. It doesn't have to be, let's try this, let's try something else, let's try something else, especially when all of those trying of this, that, and the other never, ever will ever address that underlying cause in the first instance. So if you are in a place where you really want to understand what is going on for your child, that's what we're here to do. By providing you with the knowledge, with the education about what reflux really is, about how it shows up and presents in your child, what could be going on for them, you then have the power to make truly informed decisions, knowing why you're taking particular actions, what the outcomes of those actions should be, and what you can do if you observe something different. If you want help, that's what we're here to do. Please share this